Good afternoon. Hello, everyone. Welcome to the first of 3 speed sessions on prescribing for stimulants. I'm really excited to kick off this conversation. I think it's been a point of fascination for many of us as we've kind of watched how COVID has evolved and seen some liberalization of the prescription of controlled medicines. And kind of leaves us in an interesting bind, whether it's a step closer to safer supply, bodily autonomy, or if it's a more harmful medicalization of the response, which already faces so many incursions from the medical world. So for our first session, we're taking a dive into the continent of Africa. I'm really pleased to be joined by Sean Shelley, Dr. Nakura William Ibiti, who are going to lead us in our first speed sessions discussion on prescribing for stimulants. A quick introduction by bio, and then I'll hand right over. Sean Shelley brings academic, programmatic, research, clinical, and lived experience together into a 360-degree view of the complex issues that inform our understanding and response to the use of certain drugs and the people that use them. Sean is the Human Rights and Policy Lead at TB HIV Care. He holds a post as a researcher at the University of Pretoria, co-founder and chairperson of Sandhood, sits on advisory boards around the world, is extensively published, and was awarded the 2016 SASOP Special Achievement Award for Advancing Psychiatry based on his contribution to addictions. Dr. Nakura William Ibiti is a chief consultant psychiatrist and clinical supervisor with the Addiction Treatment Services, the Federal Neuropsychiatric Hospital in Nigeria, the president of the Nigerian Society of Addiction Medicine, national coordinator, Community Intervention Network on Drugs, as a technical expert, also extensively published, and we're so excited to be with you both today. Take it away, Sean and Bill.
Thank you very much, Naomi, for this opportunity, and thank you, Bill, for joining me at relatively short notice due to my disorganized nature. But thank you very much for joining us. Yes, as Naomi says, I'm Sean, and I'm from Cape Town, South Africa. And once Bill's given a bit of background on Nigeria, I'll give you some background in South Africa. But I've been involved with working with people who use stimulants for probably over a decade now. And as somebody who's had ADHD since childhood, I'm familiar with stimulants in various guises as well from a personal point of view. So I'll be talking from both a research point of view and also from a community point of view as well during this session. Bill, would you like to maybe expand a bit on your work and what's happening in Nigeria at the moment in relation to stimulant use?
All right, it's a pleasure meeting you again, Sean. It's been a real great time, working with you over the years. I'm actually a consultant psychiatrist, been into clinical practice in addiction medicine for quite a couple of years. But in recent times, I've seen the need to move into policy advocacy because of the various issues that we have in terms of the policy direction in dealing with the issues of substance use within Nigeria. Also, very interested in understanding the atmosphere of substance use within the country. I was just speaking with you about one of the observations that I've seen in recent times, which is a massive upsurge of the use of methamphetamine in Nigeria. And honestly, I don't quite understand why that is the case. And I was very pleased about some of the explanation that you gave to me, which could possibly be the case. And so we are really grappling with the issue of the upsurge and the increase in the use of methamphetamine and other stimulants within Nigeria. We have an understanding of why some of that is happening, but not in its totality. You know that presently now Nigeria has the most deadly terrorist organization operating within its region. And they are also heavily using stimulants because this is what has been found out in many of the hideouts that have been raided and some of the conquests that the military has also achieved. But that doesn't explain the entire picture, because in the southeast of Nigeria, where we do not have these kind of terrorist activities in that particular fashion, we still have this level of use of stimulants. And so that's a real issue that is more like a burning issue now in Nigeria, and we're possibly looking at it. And I'm sure that with the help of people like you and all, that we'll have a better understanding of what's really going on, especially because of the activities between Nigeria and South Africa. So thank you very much. I think that would be more like an introductory comment.
Thank you, Bill. Yes, In South Africa, we've seen a rapid rise in methamphetamine during the late 1990s and into the 2000s. Mainly crystal methamphetamine is the most common stimulant used here. We've often seen cat or methcathinone, the synthetic form of the chemical that you find in cut, the chewable plant. That's also produced in South Africa quite a lot, and we see quite a lot of usage of that amongst the club scene. And then also we see a lot of people who are using rock cocaine, you know, the rocks of cocaine, but that's now being replaced by more methamphetamine use. And typically we were seeing a concurrent cocaine use amongst heroin users, but now that's being replaced by methamphetamine. So what we've seen in South Africa with methamphetamine is a lot of perceived mental health issues related to it. And what interested me about the prescribing of methamphetamine is the fact that we use methamphetamine and other stimulants in medical settings, and we have done for a long time. So the question to me is, if we were to prescribe methamphetamine, would it make a big difference to the harms that people ascribe to it? Of course. And with most stimulants, we know that it's very dose response related, you know, things like psychosis and which a lot of people say is caused by these drugs, but really we only see that happening in people who've got problems with their socioeconomic situation, who are using vast quantities of the drugs, and of course unregulated drugs, you don't know what quantity you are taking. And we were able to practice some harm reduction around methamphetamine use by encouraging people to use smaller doses to work out what their optimum dose is. If we were to go to prescribing of things like modafinil or methylphenidate or even some of the dexamphetamines, I'm wondering, first of all, is there space and appetite for that in amongst doctors? And especially considering that already a lot of the population can access methylphenidate. And when I was in Atlanta, I was interested to find that people were preferring methylphenidate to methamphetamine, but couldn't access it because doctors refused to prescribe it because they maybe had a history of stimulant use. I don't know if what the prescribing of things like methylphenidate is in Nigeria, but maybe you've got a comment on that and the kinds of things that doctors would be nervous about in prescribing stimulants.
Absolutely, they would really be nervous about the prescription of stimulant. You know, to start with, even methylphenidate and drugs of this nature are not even really available, even within the country. And some of the bigger issues that doctors will be a lot more concerned about is the fact that, you know, most people that are using stimulant, even with the prescription of stimulant, are likely going to be using stimulant from the streets, like street stimulant. For example, now in Nigeria, they have destroyed, I think that it should be close to about 20 ATS laboratories. So with the manufacture of amphetamine type substances in the country, you know, with also the increased use, because most of them were being exported, but some of them are being used in the country. And so some of the questions that people are asking is, if we prescribe amphetamine or stimulant, for example, that's if we prescribe stimulant, are they likely going to be using street stimulant? If the answer is a yes, then it makes it very difficult for the doctor to make that prescription because of also all the attendant effects that could happen as a result of the combination with street stimulant. I don't know what your thoughts are like, you know, with regards to that, especially with the few pilot studies that we've seen around the world.
Yeah. I think if we look at things like opioid substitution therapy as an example, I think that there are a couple of things that are important. If you want to stop people from using unregulated drugs and move to safer regulated drugs, I think you've also got to provide them in a way that allows them to achieve the same outcomes. So for example, we often see people prescribing very low doses of particular pharmaceutical analogs of street drugs, which don't even touch the surface for a lot of people. Also, a lot of it is very restrictive prescribing that you've got to use in certain settings or under supervision. And you know, if you said to people, look, you can drink as much free beer as you want, but you can only drink it in a clinic, I don't think we're going to get people going into the clinic every day to drink. It takes away the social interactions around it and all the rest. So I think that if prescribing is going to be successful in limiting the amount of unregulated drug use, it's got to mimic the availability and the kind of outcomes of unregulated drug use, but making it safer with regulated drug use. An example of that, for example, is as somebody with ADHD, in order to access methylphenidate or other medications, we don't have something like Adderall in this country, but if I wanted to access methylphenidate, I would have to go to a doctor every single month because the prescription is a maximum of a month. I would pay a fairly large amount to access the drug from a pharmacy. I'd have to go and collect it from the pharmacy every month, and I'd have to be reevaluated a month later. Whereas I can pick up the phone and wait 5 minutes, or 5 minutes meaning anything from 5 minutes to an hour, and get at a very cheap price methamphetamine, which for some people works better than the methylphenidate does. And that to me means that people are going to naturally move towards the unregulated drugs. So it's problematic if we think that it's going to be a simple thing of, oh, we've got prescription drugs, therefore we can clamp down or going to stop the unregulated drug use. I don't think we've really seen that a lot. And also, if you're not mimicking the drug that's being given and you come in with a poor substitute for some individuals, they're not going to take that anyway. So I think this is a complex issue, and we need to really get past the moral objections first.
Yeah, and I was just wondering what your thought would be specific to in terms of the goal of treatment, because when we look at opioid substitution therapy, for example, some of the goals of treatment for many people would be the possibility of abstinence down the line, or the issue of personal functioning at work, in the family, within the community, the possibility of a reduction in criminal behavior. Now, the clear-cut statistics with these kinds of issues has made it a lot more appealing for people to say, okay, I think that it is very important for us to have OST, that's in many countries. So do you think that if these kinds of goals of treatment is achievable with stimulant, for example, stimulant replacement, do you think that many more people would be a lot more ready to look at the possibility of taking on, stimulant therapy, for example?
No, look, the problem is the messaging that's out there. So if you go to Australia and you talk about ice, it's the devil's drug, And a few years ago in the United States, I found it really interesting that the Attorney General of the United States was describing methamphetamine as the most dangerous drug in the world, the most addictive drug, and all the rest. And at the same time, you had hearings in Congress where the Surgeon General of the US Navy was saying that the prescribing of amphetamines and methamphetamines to fighter pilots on extended missions was the morally correct thing to do in order to maximize the operational ability of these pilots. So the messaging is really important around this. And when we think that we've got this demon drug, we see the zombie drug Flakka alpha PVP, which of course is just a stimulant. And that story came from a really poorly reported incident in Miami. But around the world now, this is the zombie drug where people are going to eat people's faces off, and that when you've got that kind of messaging, I don't think you're going to get a lot of people accepting prescribing of stimulants. So we've got to change that messaging as well. And also to realize that some people just do better on certain drugs. So there are a lot of people in my setting that respond well to moderate doses of methamphetamine, even street methamphetamine. We're fortunate to have high quality methamphetamine in South Africa, a lot of which, by the way, is now manufactured in Nigeria, which is interesting. And now we're seeing it coming down from Afghanistan as well. But as soon as people understand that the way in which a drug is administered to a person and the setting of the drug, it's going to bring significant changes in the way people react to the drug. And of course, if it's legally prescribed, we're going to see a lot less gang activity related around the sales of the drugs if people can access it in their way. So to answer your question directly, I think, yes, we are going to see a lot of benefits. It just means we haven't had enough research done because people are nervous about it. But of course, research doesn't change people's minds necessarily, because we know that if we wanted to stop the overdose crisis in the United States, we could prescribe diacetylmorphine or diamorphine to people. And that would certainly cut down a lot of the problems that we've got, but nobody can get their mind around that, it seems. Only the Swiss have really done that, and some limited programs in the UK. Of course, the big thing is that we're going to get, like we're seeing with cannabis now, is people are going to say, what about the mental health crisis? And as a psychiatrist, you've probably seen quite a few mental health outcomes which are being blamed on stimulants, some of which aren't. What are you seeing?
Yes, incidentally, in fact, that is one of the issues that we have in terms of statistical biases. And what do I mean by biases? Most psychiatrists, for example, only come in contact with people that use drugs within the setting of a mental health issue or mental health problem. Now, so one could escalate that to mean that everybody that is taking, for example, cannabis, as an example, would definitely come down with a psychotic episode, and which is not really true. Nigeria, for example, has about over 14.3% of people in the country using drugs, with over 10 point something million people using cannabis alone. But the issues and documented cases of cannabis use in the country resulting in, for example, psychosis is not up to 1,000. And that is what what documentation shows. However, the media and the fact that people do not quite understand these statistics will make them to escalate it to that particular figure. And the only thing that I can just remember is what Ronald Cohen said, that if you torture data long enough, that it will confess to anything. So that's really the problem that we have in terms of the statistics, using the media hype and the statistics and what people see to determine whether something is acceptable or not, or whether it should be prescribed or not. But I also have another concern, especially as a community member. And so my question is that, what really are your thoughts in terms of the possibility of balancing the issue of autonomy, human right, and safe supply of this, that medication in the face of all that we are talking about? What I'm saying, if someone really would need a prescription for a replacement, and the person can function adequately when we do that to that individual, if we deny it to that individual, how does that play out to the issues of autonomy, the issues of human rights, and the concept of even the safe supply of these medications?
Yeah. So that's a really interesting question in the South African context in particular, because when the cannabis ruling came about to decriminalize the possession of cannabis and move towards legal regulation of growing of cannabis and private use of cannabis, that judgment was not made based on harms. It wasn't made based on any other argument apart from the fact of bodily autonomy and the right to use and the right to put into your body what you want. And by extension, that means that ruling could apply to any drug in the country. The only time that you would be able to block that from a constitutional point of view in South Africa is if there's clear evidence that the regulated version of that drug would cause more harm than the unregulated version. And we know that that's not going to happen. South Africa is also an interesting place, though, because when you use alcohol as an example, and you say, can you imagine banning alcohol? A lot of people in South Africa would say yes, actually, and we think you should, not realizing the added harms that would come to that. And we've seen prohibitions on alcohol sales during lockdowns and that, and it certainly did reduce trauma and that, but that's now being hyped again to say, oh, maybe we should consider not selling alcohol at all, or putting really draconian limitations on alcohol. The one thing I do think, though, is that the advertising of any medication or drug direct to consumer should be limited quite strictly. So I don't think we should have the aspirational advertising for alcohol. I don't think we should have it for cannabis, for example. I think that we often become conflated between adult use of cannabis and medical use of cannabis. They're two very different things, although a lot of people will use a drug for self-medication, which moves towards the medical use, although they're still using an unregulated version of it. I think that there is a balance to be had between bodily autonomy and the general public good. But if it was about harm, we would ban free climbing, we would ban a lot of extreme sports. So it's not about harm. What is it about then? I think it's really about a moral issue and a societal issue that, A, we don't like people finding other ways of coping with the world beyond church and state. And we also don't like people exercising their bodily autonomy in certain areas. So it's complex. I think there's a lot of morality involved in it. I certainly think that the prescribing of a medication which is perhaps being used for non-medical purposes, for adult use purposes, runs the risk of turning everything into a biomedical intervention. You know, we run the risk of ending up with a society where only a psychiatrist can prescribe, say, diamorphine or methamphetamine to somebody who's dependent on those drugs or chooses to use them. And that's going to create a cost barrier. And once again, the poor populations are not going to be able to access it. And the economies that are built around the illicit drug market are also going to suffer. And in the South African context, that's not necessarily a good thing all the time, because there are whole communities that survive purely on the trade of unregulated drugs. So these are complex issues we've got to think about. But I think certainly in the short term, medical doctors should be able to prescribe these drugs based on their discretion and based on the individual in front of them, without it becoming a problem in that the offenses of accessing unregulated drugs become so draconian that that population suffers unduly.
Yeah, and just listening to you speak, I don't think that there is any disagreement as to why most of these drugs it's very difficult to legalize their use or their prescription, if I should put it in that particular manner, because to a great extent, the government are not likely going to do that in most cases. I mean, if we take, for example, the WHO recommendation regarding cannabis, even with WHO's recommendation regarding cannabis, they are still finding it very difficult to decide about how to schedule cannabis, for example, as a drugs. And that speaks to the issue of the politics, surrounding some of these drugs and the kinds of decisions that are being made. So oftentimes, I think the decisions that may be made by government at the end of the day may not really be, as far as I'm concerned, rational. And then the other issue that is of concern to me is the concept of risk. We tend to speak about risk as if they are objective indices. But I want to disagree very thoroughly that risk is completely very subjective as far as I'm concerned about. For example, we speak about the risk of the harm as a result of the use of cannabis, for example, being very high, when indeed research has shown that alcohol is a lot more harmful drugs than any of these other drugs that we'll talk about, but yet it's a drug that is legal, it's a drug that is acceptable. Now, but if we were to go to stimulant, for example, so as a community member, what do you think could be some of the greatest barriers or to the uptake and the implementation of prescribing stimulants? I mean, I am now speaking from the point of the community member. What is supposed to be the barrier to the community member uptaking these kinds of services?
That's something that I've had to come to terms with myself. So, for example, I know that I do particularly well on a particular stimulant that's not available medically in South Africa. The only way I can access it is through what's called a Section 21, where you have to apply to get this particular drug. And so one would think that I would be well motivated to get it because it improves performance, it improves the way that I function, all the rest. But knowing that people will then be able to see that I'm accessing this drug, how much I'm accessing, what quantities, what dose I'm taking, is something that stopped me from doing that in the past, in particular because it's National Department of Health and people that I work with and that kind of thing. So I think that the number one thing is if the barriers to entry are too high in terms of what a person's expected to do in terms of accessing that medication, are you going to keep a record? Is the DEA going to have access to their records, for example? I think that's going to be a huge barrier. I think cost is also going to be a massive barrier. And there are models that have been applied in the past to overcome these kind of barriers. So if we think about the original harm minimization clinics in the Merseyside in the 1980s, we had social workers who had relationships with the community, who were distributing injectable methadone, for example. And I think people forget that there's something in the ritual of drug use that's very important as well. So for some people, the act of injecting is as important as the drug itself. It adds to that. For myself, perhaps that wouldn't make much of a difference, but for a lot of people, it does make a difference. And the same with stimulants. Some people want to smoke their stimulants. Some people want to swallow them. You know, there are a variety of ways of taking them. Some people want to snort them. We should have a variety of options available, and minimize the numbers of points of contact that the person has to have to live a normal life without disregarding the issues of their safety and their choice. Ultimately, we want people to be able to make a well-informed, conscious decision about whether or not to use drugs, and that use should not impact on their freedom, their opportunity to work, and their acceptability and psychosocial integration with society. I think there's a lot of challenges there, just the prescribing process. And how do you think we could get past that? Have you had any ideas on that? Sorry to throw you in the deep end there.
Yeah, because I've really been thinking about some of the things that, that some of those issues that may really make it difficult for people to have uptake these services are the issues that you've just mentioned. And they are actually roadblocks to for these people being able to access these services. The other one that I'm thinking about is, if these are services that are supposed to be offered by or prescribed by psychiatrists, for example, so how many psychiatrists do we have in some of these countries that would be able to make that prescription? And how far would you travel to get to a psychiatrist? We do not have psychiatrists in the villages and the counties. We only have them in big cities and all that, working in big hospitals that many people do not want to go to. For example, in Nigeria, the entire the number of people with substance use problem that are accessing the model treatment centers owned by government, if you put all of them together, because I work with them in the West African Epidemiological Network on Drugs, we found out that it is not up to the number of persons that are seen by just one NGO alone. So you could see that the entire federal government establishment with big hospitals, big setups for people with substance use problem to go to, do not see as many patients as the number that are going to just one NGO. So access now becomes a problem, because even if the services may be available, people may not want to access it for a lot of issues. And I also see that playing out in this particular case. I know that our time is really, just running in, but I may just need to ask a quick one, which is, I don't know your thoughts whether if we were to have a guideline that establishes the prescribing practice, whether that could make a difference. The reason why I'm asking this is that in Nigeria, we just finished developing our OST guideline. We're just about to validate it by next week. We're including that we can prescribe methadone for someone that was abusing or using pentacecine, for example, because we have a lot of double amputees as a result of the use of injection of pentacecine. So we have set that as a guideline for us to be able. So do you think that if we have a clear-cut guideline, that it could make a difference in terms of, people being much more confident in making the prescription?
I think guidelines are essential. Of course, the problem with issuing guidelines is that somebody will no doubt clamp down on them as well. If you issue guidelines around maybe prescribing methylphenidate to people with substance use issues, then you open yourself up to to them actually legislating against it. But in principle, guidelines are excellent, and they're essential. I'd just like to say to those listening, if you've got questions or comments, please type them into the chat, because we would appreciate having some questions to help guide this conversation, because we don't presume to have any of the answers, let alone all of the answers. But I think it's an important conversation. So yeah, I think that guidelines are critical. I think that guidelines need to be informed, though, not only by the medical fraternity, but by the community of people who use stimulants, you know. And really, we also need to start working on campaigns in the media and that, because there's so many advantages to prescribing, and as a first step towards regulation of drugs. I think it's critical that we start doing this. And there've been some brave doctors in the past who've gone against the norms and provided things like OST prescribing, or I know of doctors who prescribe morphine to people who haven't responded well to methadone in South Africa. And I applaud those people, but we need more of that. We need, I heard it. The first time I realized the extent of my ADHD was in a lecture by a Dutch lecturer, and he was describing my life as a pathology, which was a very strange experience for me, but also helped me realize what a lot of other people go through. But the good thing about what he was doing was he was saying, when somebody's got a stimulant use issue, don't not prescribe the very thing that's going to help them if they've got a concurrent ADHD issue. The ADHD is not caused by the stimulant use, it's resolved by it. And so he was very in favor of prescribing whatever the person needed. And I think that we need to get that kind of attitude going forward, to ensure that there are people that break through these barriers and start doing it. Because if you think about it, we've got so many regulated medications and drugs already, which are analogs of unregulated drugs. Surely we should just be able to shift over quite simply based on the evidence we've got.
Yeah, and I was also wondering what more we could do, because that is what actually moved me to the sphere of policy advocacy and all that, in terms of what more we could do in dealing with the issues of how the government in itself and the media in itself, in terms of the narrative that they provide. I give you a typical example now in Nigeria. We're having one of the worst insecurity crises in Nigeria. Maybe because of the terrorist activities with the Fulani herdsmen, and it's causing a lot of food crisis in the country. And incidentally, the presidents and the government, the law enforcement officers are saying in the entire country that the cause of this insecurity is drugs. Yeah. Now, that makes it very difficult to have a conversation as to finding solutions to some of these issues that we have. For example, making the necessary prescription for someone that may require it. Now, these kinds of discussions loses the basic elements of what some of the things that we could be looking at. For example, in Nigeria, we could be looking at the, some of the Islamic fundamentalist ideas associated with, ISWAP, that is, creating the problem in the country, that is causing the terrorism in the country. But it's easier for you to say it is drugs, because drug users are very vulnerable and they can easily be cracked down. And the more they crack down on them, the more the government defines its success of fighting insecurity by the number of people that it's arresting. So some of these things is creating a whole lot of problems and also creating fears in people. That is on one end. On the other end, we seem to conflate the concept of legalization with legal regulation. Legalization is just a way of making something to be legal, and all that. But legal regulation is about government taking control of how that thing is produced, how it is distributed, how it is manufactured, who gets it, who has the possibility of prescribing and all that. And so I am beginning to talk a lot more about legal regulation in many of these things. And I'm beginning to, with our conversation going, I'm beginning to think more keenly about who do I see in my day-to-day practice that may benefit more from for example, a trial of an amphetamine or of a trial of a stimulant prescription, who is actually dependent on stimulants and has a stimulant use disorder with a lot of issues and problems, and to what extent can it really help the person? Because if we can improve personal functioning at work, functioning in the community, I think that's something that should be considered. I don't know what you think.
Absolutely, and I know from when I was working at a location in Lavender Hill, where most of the people were gang affiliated. Most of them were using methamphetamine for many years. I think more than 1/3 had had an admission for some sort of psychotic issue within the past 12 months. Almost everybody had spent at least a week in jail in the previous year. I saw that just by introducing concepts of harm reduction and speaking to people about dose response and just closing your eyes for 4 hours every 24, even if you're not sleeping, of good nutrition, those kinds of things, I saw massive changes, drops in hospitalizations, drops in levels of psychotic symptoms, all of those kinds of things, more stable lives and that. And if that makes a difference, which people are reluctant to do, how much more so if you're getting a drug of known strength and you know what you're taking, and you can say to yourself, right, okay, well, I now know that I need to take X amount per day. Whereas I've yet to find an accurate measure of what people in the South African context are taking. Nobody's working out how much methamphetamine is actually taken into the system by smoking perhaps half a gram of methamphetamine. And I think that with decriminalization of drug use, we're going to see a natural improvement in the quality of the drugs. And if we've got prescribing, we've then got a very good source of better quality drugs. And Howard Becker, I think it was, who said, the problem with our drugs, our drug problem, is not a problem of drugs, it's a problem of quality of drugs. And I think that's very true. So hopefully we can find ways of not keeping this purely in the biomedical realm. And I certainly think that your suggestions have been very, very helpful in my thinking. I'm
just wondering whether we will ever get to that point where the emotional tail will not be wagging the rational dog. The reason why I'm saying that is it seems as if many decisions in this area, even by experts, are really tainted a lot by, beyond cognitive biases, cognitive illusions, the concept of, statistical biases that people see. Because we just finished one of the conferences that I just attended, and there were mainly psychiatrists that were in the room. And I was really shocked at their level of concern over attributing the various kinds of problems that they have to substance use that people have in the country. And when I was actually particularly asking them for the statistics that they had to show for that, they were telling me about the patient that they are seeing. And I was asking them, how many patients have you actually seen? And how many people exist in the country that you are conflating what you see? It's just like if you go to the maternity home and then you are seeing in a maternity home, you are seeing a lot of pregnant women, and all of a sudden you assume that almost every woman in the country is pregnant. No, you went to a maternity home, so you should be seeing pregnant women all over the whole place. So if you are treating people in a drug treatment center, you should be seeing people with substance use problem, and not necessarily that everybody that is in that country is having a substance use problem. So that in itself seems to be creating a lot of issues in terms of how even experts are approaching the topic.
Of course, and one of the thought experiments I do with people is I say two things. I say, first of all, imagine your child is caught with drugs on them, and who do you want them to see? The policeman or a caring family member? It's obvious. You don't want them to go to the policeman. Not much good comes out of that. And then the other question I ask is, imagine your community without any drugs in it whatsoever. what problems have you actually solved at the end of the day? And now imagine that community where you focus on solving the problems of unemployment, the exclusion of certain people, of marginalization of people, of lack of economic opportunity and lack of education. If you could solve the education and unemployment problem, how do you think that community would improve, and what would happen to the level of drug use? And they all can tell you that drug use would drop and the community would be far better. And if there were no drugs around, some people actually see the fact that there probably would be more problems. But they can't translate that into government policy in any way. And I think that the level of disdain people have for people who use drugs is seen. And as Vincent Hesse pointed out in the comments, we've seen these things work in Liverpool and Wirral in the first harm minimization centers, the work of Pat O'Hare and people like John Marks and Julian Buchanan and all of those people. We've certainly seen this work, and we've seen the prescribing programs for heroin work. Why are we so intent on having people die clean and rather live while taking certain drugs? And surely there's an ethical issue for doctors there as well. And I would argue that look, if I was a practicing clinician, I probably would have been kicked off or have my license revoked, because I couldn't imagine not prescribing certain things. I'm not saying I expect other people to, but from my personal perspective, I think I would find it hard not to break some of the very stringent rules there. So it would be great if we could get more people like yourself, Bill, who are already, you've done a great, strong voice to criticize these cognitive biases. And what's really interesting to me is we talk about people who are so-called addicts and addicted and say, look at the irrational decisions they're making, but we're making hugely irrational decisions in day-to-day life. It's part of the human condition. We're moved by our heart and not by data. And how do we interpret the data into narratives that people can identify with, and brings about a shift in heart? So I think our conversations are important.
Yeah, no, definitely. In fact, I'm beginning to think that maybe some of the things that should be done at the moment is to begin to articulate the treatment resources that are even available to us, for example, and think about what is the level of community support that we can get in addressing some of these issues, and what are some of the monitoring templates surrounding the issues of these kinds of prescription. The reason why I'm saying so is that even in other cases, like in the OST, in isolation, it does not seem to have as much impact as when we consider a comprehensive kind of approach to the issue. Does this person have legal problems? Can we help to sort it out? Does he have transportation problems? Can we deal with that? Are there vocational issues and the lack of skills and education? Is it possible for that to be dealt with? Does the person have HIV, and can we also address the issues of HIV? Are there comorbid medical or mental health issues that we need to address in this individual? Now, when we address all these issues in conjunction with whatever prescription that we're making, we see that the outcome is usually a lot better. The reason why I'm saying so is that the few reports that I've read about the piloting of stimulant prescription did not in itself speak so much about all these supporting kind of programs, which are a necessity to the effective outcome when you are making prescriptions of that nature. So I'm thinking that going forward, that those who are interested in getting involved must also consider all the supporting kind of programs and treatments so that the effectiveness can really show. Because if you are making a prescription for someone that has amphetamine use disorder or stimulant use disorder, and then you made a prescription of a stimulant for the person as a replacement, and this person has issues in terms of work, he doesn't have work, he's homeless, he's walking down on the street and all that, and at the end of the day, it doesn't seem to be quite effective from the outcome, then the problem could well have been that we didn't deal with some of the base issues that are very important to this individual, which is like housing, like getting a job and things of that nature. So maybe there has to be consideration of some of these things in designing that program, so that we can truly see how much it is working.
Yeah. I would agree strongly. The one thing is that services should be voluntary, though, and what we've seen in the United States with OST prescribing, in particular with methadone, is huge restrictions on expecting people to go every single day to collect their medication, that they have to attend sessions to sing kumbaya to each other and hold hands with people they don't know, that they're expected to be immediately abstinent from all street drugs, that they can't cross state lines, that they can't get employment. And that really is putting somebody at a huge disadvantage already, that they can't get, you give them the means to get on with life, and then they can't get on with life because of the restrictions that you place on them. But looking at comprehensive services, that is essential, that the person slowly, as they start engaging with services and start to trust services, can engage and get housing. We know housing has a massive effect on the levels of problematic drug use. We know that people who've got meaning and purpose in their life find it much easier to reduce their drug use to levels that are not necessarily problematic. The other thing I find really interesting with stimulants is that if I went to my doctor and he prescribed me methylphenidate, for example, and I said, you know what, doctor, I take my methylphenidate and I save it all up until the last weekend of the month, and then I take half of them on Friday night, I party all the way through to Sunday, take the other half on Sunday, then party through till Tuesday, and then crash for a little while. He would say, no, that's really bad. It's dangerous. You're at high risk. You're abusing the medication. But if I go and say, you know what, with my methamphetamine, I take 100 milligrams per day in the morning, every single day, then they would tell you, no, you're dependent and you shouldn't be doing that. What is it? Make up your mind. That to me is really interesting because when you're taking your drugs like a medication, then that's something that I think is something we need to consider. I see there's a question here from Shirley. From Sam Shirley Bevan. Hi, Sam. Would it be useful to see new protocols from other countries on prescribing for stimulants for doctors? And to what extent can experiences guidelines be transferred between contexts? Do you want to have a go at that, Bill? Maybe talk to that.
Yes, I agree with her that or with him that I think it's important to see what protocols that they actually have in place in terms of sharing, not just the protocol, but sharing practice experiences, because we must understand that that very many of the things that finally get to the point of protocols and guidelines are usually derived from practice and experience. And so, sharing these kinds of experiences are usually very important, so that the people that are making whatever guidelines later on in their countries would always do better than the one that started it, because they would have learned from other people what they have done in the past, what really worked, what didn't work, why didn't it work, are there differences in context and all that made it not to be very effective in this particular place, but effective, So yes, I agree that there is a necessity of the opportunity to share these kinds of experiences. And that's actually what we're doing. And that's what I was also talking about while looking at some of the published papers in some of these other countries, and some of the gaps that, if we possibly introduce, may improve what the outcome is. What do you think, Sean?
Yeah, I'm sorry, you cut out a bit there towards the end, Bill. So I didn't get the end part of the question.
Yes, what I was saying is that, that's in brief, is it would be good to share practice experiences within colleagues. And we must also understand that whatever protocol that we see was derived from practice and experience. It is practice and experience that leads us to the point of developing protocols. And so it is always good to share these kinds of experiences, so that in the people that are trying to develop their own protocols, they may get to understand, why did it work? Why didn't it work? Do we have a different context? Can we do things differently? That these kinds of sharing of ideas and experiences is always very important. I don't know what you think.
Yeah, no, I think it's really important that we do share, and these platforms like this are extremely valuable. I think that one of the things that as harm reductionists we should all look at is a set of principles and strategies that can be applied universally, and I think that can be transferred between contexts and even different drugs. Whereas to have very strict protocols and guidelines, they can differ from context to context. Although I think each region or each location should certainly develop them. But if we look at, for example, harm reduction, for me, some of the principles are the principles of drug set and setting, the principle of any improvement is an improvement, that change is incremental usually, that people, that truth follows trust is another one, that it's only when people trust the system and trust you that you're going to find out the truth of their existence. And these can be applied to any situation. So no matter what the drug is, if you look at the drug itself, what's the dose response, the means of ingestion, what the perception, what the pharmacological action is of it, and then you look at the set, how the person thinks about the drug, what the drug expectation is, and then you look at the setting, or the systemic influences of the pharmacological outcome of the drug. That you can change one of those to reduce harm. And that's a set of principles that you can apply in any setting. And I think with stimulants, it's no exception, and perhaps more so because it's a less obvious route to prescribing. And when you start looking at things in totality, as I think you were alluding to this earlier, Bill, or actually saying it, you start seeing a holistic picture of the humanness of the individual. And it's only then that we can decide that yes, we must take whatever pragmatic step is going to make this life better. And it's not the same for the next person. It's not just a blind free market approach,
Yeah, and that's why, when we stick, because whatever protocol that we are going to see and get, there is a tendency that we can do things differently depending on the individual. I give a typical example. I have made prescriptions. If I tell people the dose of diazepam that I've given to some people, they would never believe it, and I'm sure that I would lose my license, because that particular person, it was a different thing entirely. I gave someone about close to 150 milligrams of diazepam, and nobody believed it. And I was still conversing with him and speaking with him.
Yeah.
And that was very unusual. And the resident doctors were just wowed, because they just sat down there and they looked at this individual. But if I was to stick to what is in the books with regards to what you can prescribe and what is the limit of the prescription, there is no way that I'll make that kind of prescription. Now, I am saying that within the context of people differ, and we should have an individualized approach to the treatment of individuals. And so in the case of stimulant prescription, I'm sure that those who are in practice will definitely see people that they believe that could benefit from these prescription. And if you think that someone can benefit from it, then there could be a trial. That is one. Secondly, you said something. If the person is going to be better off with this prescription, then why do you withhold that prescription? Because first of all, as a doctor, you should do no harm, and you should try as much as possible to see how you can benefit the person by your care and treatment. And so if what you're going to be providing to the patient or to the client is going to be a lot more beneficial to the person, then why not? So in other words, I'm speaking to the fact that if we begin to see things from that point of view, then we may be making some prescriptions, in this case for stimulant use, and see whether it will be effective to the individual. Yeah.
No, totally. I think we're into the last 5 minutes. If there are any final questions, that would be great. But I've seen some of the comments which have been really interesting. In particular, it seems to be almost like back to the future, that we need to go back to a lot of the principles that were applied early on, which were based in pragmatism and compassion for people as a whole. We've got to avoid trying to rescue people and presenting ourselves as rescuers, but rather embrace people and meet them where they're at, and really understand what their complex needs are, because people have been so marginalized just because of the use of drugs. I think it's ridiculous. I think if I've got one message to the world, it's some people do better on heroin, some people do better on methamphetamine, some people do better on nothing at all. And we need to just get over it and accept it and help people live the best lives that they possibly can. I see there is a question here from Pat. Sorry, I'm just going back to have a look at it, Pat. Sorry, I didn't. Oh, yes. Okay, why was... I'm sorry, I don't understand the term remit in this context. Maybe Bill does.
I don't really also understand that last part. The remit. I don't understand what that means. I don't know whether the person can quickly clarify that.
Yeah. Sorry, as I say, but I don't understand the term remit as such. Why were psychiatrists given drugs? Okay, yeah.
Okay, no. Or should I assume that that what the question is? Why were they put in charge of drugs? Okay.
Oh, I understand totally. Yes, and that's a really good question. Yeah. Yeah. Well, maybe you want to answer that as a psychiatrist. I mean, I'm on an award.
Yes,
which is a double-edged sword. Yeah.
Yes. I will tell you why psychiatrists were put in charge, because all these issues were put within the realm of mental health issues. And that is why in many countries, like in the developing countries, Nigeria, for example, in fact, for many years, the federal government did not have drug treatment facilities outside mental health facilities, because they were subsumed under the mental health fabric and all that. And that is why psychiatrists are given that. But we are also seeing more and more that most persons with substance use disorders do not want to go to those facilities within the mental health facilities. They would rather prefer to go to standalone kind of facilities. They would prefer to go to drop-in centers. They would prefer to go to other places to have this treatment being done. And we're beginning to see the need for government to think in that particular light. But just to answer your question, I believe that is the reason why psychiatrists were more or less put in charge of making those prescriptions. I don't know whether that is also the case, Sean, in South Africa.
It is, and it's problematic because psychiatry really suffered in I think it was around about the 50s when there was this separation between psychology and psychiatry, which took place due to some really bad biases that linked correlation to causation, looking at how people dreamed and didn't dream, and there was this conclusion that we were far more controlled just by biochemistry from a reductionist point of view, and so psychiatry became tremendously reductionist without embracing the mind. Rather, it became a thing of the brain. And we know that there is no predictable chemical cascade that happens each time people take a specific drug. It differs, drug set and setting, back to Zinberg, the timeless work, which we forget about. And I think that highly qualified experts are really great, and we need them. We need psychiatrists for certain things and that, but the control of psychotropic medication should not just be in the control of psychiatrists or even necessarily the medical fraternity totally. We need to see things from an anthropological, from a human point of view, and from a bodily autonomy point of view. And I think that we create far too many barriers by keeping it in the remit of psychiatrists. There, Pat, you see, I've learned a new word, to use a new word. So thank you. So as you say, pathologizing of a social phenomenon. And this way of turning patients into prisoners, or prisoners into patients, and then back into prisoners through being a patient, that is a major issue. It is just another form of control. Prohibition is moving from prohibition to pathologization, and if we're not careful,
absolutely,
we're going to be institutionalized again. Bill, final comments, because we are on time.
Yes, well, my final comment is that as experts within the field, as people who are interested, as people who are using drugs, there is a greater need for us to have a better understanding of what works, and we must move towards the direction of realizing that if there is any benefit in any intervention, that should be the way to go. And if there is a benefit in the prescription of stimulant for people with stimulant use disorders, then as experts, we must consider it. Our role is not to moralize, and our role is not to determine what is good for the patient or for the person that is involved. As far as there is no harm that is going to come to the individual, or there is less harm in an intervention, that is something that I think that we should rightly be able to consider. And in this case, if stimulant prescription does that, then as experts, we may need to look into that. Yeah, Sean?
Thank you very much, Bill. I really appreciate your time. It's been great talking to you. Thank you for everybody for listening. I think this is really an important thing to talk about, and hopefully the other two sessions in this triad of sessions will build upon this. So thank you very much to everybody. Thank you very much to
thank you,
Harm Reduction International. Thank you, Bill. Very much.
Thank you very much.
Appreciate it a lot.
Yeah.
Really great. Thank you.
Thank you very much.
Tune into Carl Hart. He's next.